Thank you, ma'am, for your very, very kind introduction and words. Without much ado, I will proceed further to my talk. I will be addressing about diabetic macular edema and taking through some cases. So, as we just saw, it is diabetic retinopathy is one of the leading causes of loss of vision, and macular edema affects reading vision. And around 50% of the world would experience a loss of more than 2 lines in 2 years of follow-up. Various studies have shown the impact of this. And as we know, the diabetic macular edema is multifactorial. There is hyperglycemia, it alters the retinal blood flow, it leads to hypoxia, inflammation, oxidative stress. All of these various factors are produced, of which VEGF is of course the one which has gained the most importance, causes breakdown of blood retinal barrier, and then these lead to the formation of diabetic macular edema. So just as the pathogenesis of the whole thing is complex, we need to take into consideration a lot of various factors when we are managing our patients with diabetic macular edema. What is our goal of treatment? We of course want to reduce the amount of edema. Maybe angiographically you would want to reduce the leakage. Maybe on imaging you would like to reduce the thickening. But finally what you actually want to do is you want to improve or stabilize the vision of the patient, and that is the most important goal. Now, the success of our treatment, other than all the things that we would see, would also depend upon how well is the glycemic control of other systemic parameters like hypertension, anemia, their cardiac and renal status. Renal status can impact retinopathy very adversely and badly, their lipid profile. So having not just an evaluation of the OCT or the FFA or the OCTA, but also a complete evaluation of the patient. Like we just said, many a times they will be just getting some sugar checked and having some kind of medication, but a lot of the other parameters may go unchecked. Insisting that they get this done and communicating it to their physician to address all of these factors and bring them under control is paramount in us achieving a success in our management of diabetic macular edema. The evolution was started with the use of laser photocoagulation, then came in triamcinolone intravitreal usage, then we came to the era of intravitreal anti-VEGF agents, and now we are having more and more things coming in every day. So in 1985, ETDRS showed the role of focal laser in diabetic macular edema, and it showed that it could reduce the chance of significant vision loss in patients. These could be divided grossly into focal, wherein you are hitting the microaneurysms with laser. You could have a grid wherein whichever is the area of thickening, that is where you would do the staggered pattern of laser, and what could be called as a modified grid where you combine these two. So in this eye, you have all of these, you can see numerous microaneurysms, and there would be thickening in this area, and that is where the laser would be done. Multiple anti-VEGF agents, bevacizumab, ranibizumab, aflibercept, conbercept, which is not available outside China and certain areas, and there's brolucizumab, and now we have faricimab also. Multiple molecules available. So the gold standard as of today for management of diabetic macular edema is intravitreal agents, in which we have the various anti-VEGF agents, and we have steroids, which is mainly triamcinolone and acetonide and the dexamethasone implant. Again, the fluocinolone ILUVIEN implant is not available in India. And lasers, they play an ancillary role in today's management of DME, used for non-center involving DME, and adds an adjunct to injections, especially when you have multiple microaneurysms, which can help in bringing down the load of treatment. Anti-VEGFs are the first line of treatment. They block VEGF. They are safer in the sense they do not cause a rise in intraocular pressure or cause a progression of cataract, unlike steroids. They also, as we know, are used preoperatively to reduce vascularity of membranes, but they do have a cardiovascular risk factor. Steroids are usually used when there is a poor response or non-responders to anti-VEGF, can be used first line in chronic cases or where there are extensive hard exudates. Yes, there is a risk of IOP rise or cataract, which is lesser with Ozurdex, but IVTH triamcinolone is the cheaper alternative, which can make it more accessible to a lot of our underprivileged patients. When there's a patient who has a history of a recent cardiovascular event like a myocardial infarction or a stroke, usually anti-VEGFs are avoided for up to 6 months following the acute event. And when will we switch treatment? And can we use steroids as pseudophakic eyes in first line? A few of these questions should be answered over the next few cases that we'll see. So this is a case where we have used laser treatment. You can see there's a little bit of macular edema over here, which is non-central involving. There are few microaneurysms over here. So discrete focal was done to this, though of course the patient at this point also had good vision, but it was coming near the macula, a small amount of focal, it has reduced to the edema post-treatment. You can see the few hard exudates have also resolved, and this can help the patient from progressing to further also sometimes if you have caught them early. Another case, this is the left eye of a particular patient. You can see there's diabetic macular edema, there's subretinal fluid, and this particular case demonstrates a finding called hyperreflective foci, which are seen on imaging, and there are very few of them. And this eye shows good resolution with a few injections of anti-VEGF. But the contralateral eye, which had numerous hyperreflective foci and also more edema, here, despite multiple anti-VEGFs, we do not have a very promising response to treatment. So then the patient received IVTA. There was a transient response, but the edema recurred within 3 months. And then the patient went on to receive Ozurdex in this eye, and then there was some amount of response. So one of the biomarkers described in diabetic macular edema are hyperreflective foci. These are small punctiform lesions with a reflectivity equal or higher than the RP, about 20 to 40 microns in size, and are seen distributed throughout the retinal layers on OCT. They are not seen clinically or on fundus photography or autofluorescence. And we did a study wherein we found that the inner retina was the most common location for the hyperreflective foci, and also the number of hyperreflective foci was more in the inner retina as compared to the outer. On regression analysis, that we found that women were 3 times more likely to have hyperreflective foci. Those who had cystoid spaces had 2.595 more higher incident, and with those who had subretinal fluid, there was a higher incidence. Interestingly, higher triglycerides correlated to lesser hyperreflective foci. So we postulated that the hyperreflective foci could be of an inflammatory origin along with the neurodegenerative process that plays a part. And these may require more, eyes which have more hyperreflective foci are likely to require more aggressive treatment and more prolonged need for treatment for stabilization, and may also require steroids for ultimate stabilization. This is another case where we have a 60-year-old gentleman, a diabetic hypertensive, fairly good control. His HbA1c is 7, his cholesterol is 266, a little bit on the higher side, comes with defective vision. These are his baseline images, 618 in the right eye, extremely chronic edema, 660 vision. You can see a lot of hard exudates also, they are pretty evident on this image here. A lot of disruption even of the outer retinal layers. This patient, we gave him aflibercept, and you can see this is after the first injection, receives a second injection, and this is after the third injection. And there was an excellent response to the edema. There was a good reduction of edema. You can see here the hyperreflective, the hard exudates are also reducing. The outer retinal layers are forming, and the vision has improved from 636 to 612 parts. Following this, the right eye was observed since it was quite dry and had reached a vision of 6 parts, and the left eye continued to receive injection, and he achieved a vision of 6/12 in the left eye. Macula remained dry, and he was able to sustain this improvement in vision for about 2 years following this. Of course, he also maintained his good systemic control. So outcomes with aflibercept, whether you look at the drug trials like VIVID and VISTA, have shown comparatively better visual and anatomical outcomes. The same was also seen along in the protocol T of DRCR-NET, where patients, and also has shown that patients who have poorer vision at baseline have better improvement in vision on using aflibercept as compared to ranibizumab, and also better reduction of central macular thickness. Another case of a patient with DME who had received multiple Avastins and had a poor response. He received an Ozurdex injection. Ironically, 3 days after the Ozurdex injection, he had an acute myocardial infarction, which had nothing to do with our injection, but more to do with the systemic status. When he reviewed back to us after stabilization of his cardiac issues, about 3 to 4 months later, the edema had resolved. So we went back with injecting Ozurdex, and he had a good resolution. So steroids have anti-inflammatory and also maybe a slight anti-VEGF action, and they influence the non-VEGF mediated pathways that contribute to macular edema in DME. Ozurdex implant has a comparatively lower IOP rise and incidence of cataract as compared to IVTA. The important part here is that the implant has the same half-life in a vitrectomized eye as in a normal. So otherwise, when we have edema in eyes which are vitrectomized, using any drug is difficult because the half-life of anti-VEGF is drastically reduced since there's no gel to hold it back. IVT also just disperses everywhere, makes the vision cloudy for a few days and then just gets washed out, but this stays for the same amount of time. So it's the choice of agent to be used when the eye is vitrectomized. But you have to be very careful while injecting, since the pellet can go in at an extremely rapid force and can sometimes hit the retina and cause a bleed or a flake. And in a patient where the PC is not intact, it can migrate into the anterior chamber also. There are multiple reports of this also. This was a patient of ours who had chronic macular edema following scleral fixated IOL. And we found the implant in the AC after 2 days of injection. Thanks to my colleague who was very agile and put it back inside, and thanks to the implant which decided now I'm going to stay here, so the patient could have the benefit. Otherwise, very often you need to remove it, and that really leads to a very upset patient because they have spent a lot of money and now the drug is also not there in their eye and everything. Hard exudates, extensive hard exudates at the center of the macula, possibly steroids, but anyways, once they are there in the center of the macula and they are going to fit there and form a scar, the vision is of course compromised in the center. There's another finding which has been gaining importance now is what is called as intracystic hyperreflective material, ICHRM. So these are known to be associated with poorer visual outcomes. They indicate a more extensive breakdown of the inner and the outer blood retinal barrier, and there's a transudation of proteins and fibrins and macrophages happening here. They can have large microaneurysms with them. They can have a lot of hyperreflective foci. They can have outer retinal defects. And sometimes they resolve and probably that material sort of aggregates together to lead to the formation of hard exudates. This is one of our case who has this large cyst with this ICHRM, and we have opted to treat this patient with aflibercept, and there is some reduction after one injection. The patient is still under follow-up and undergoing treatment. Chronic edema of this sort, of course, the patients would have very poor vision. There's extensive outer retinal loss, extensive ischemia. One may attempt treatment with steroids or maybe do some laser or grid to whatever microaneurysms, because visual prognosis here would remain quite poor. Fluorescein angiography, and now being more and more replaced by OCTA because it's a non-invasive procedure. Mainly the role would be to define macular ischemia, especially when you're having a poor response to treatment, and also maybe to look for peripheral non-perfusion in the relation to diabetic macular edema alone. So another drug which has come in now is brolucizumab. So here is one case example, 618 vision following 6 Avastins. There's not much of change. The edema has remained status quo. So the patient receives a couple of injections of brolucizumab. There is some reduction of edema and one line of improvement in vision. Of course, there's also a ERM forming over there, which is also having a tractional component to the edema. So in AMD studies, one of the commonest concerns that everybody has with the brolucizumab is the incidence of intraocular inflammation. And the studies have shown a lower incidence of inflammation in patients who received it for diabetic macular edema as compared to those who received it for AMD. And so possibly it's a safer alternative. Patients can have sustained and a longer term resolution of edema with brolucizumab. So again, another lesion which has gained a lot of importance are these things. They are called as perifoveal aneurysmal anomaly or TEL caps, telangiectatic capillaries. You can see here and here. These also exude a lot, can cause a lot of hard exudate deposition. So, and show very poor response to any form of intravitreal injection. You need to do a laser to help in closure of these lesions for your macular edema to respond, in addition to whatever other anti-VEGF or steroids that you may use in the particular case. Another cause is vitreomacular traction or surgery for DME. So most commonly surgical intervention is not the first choice of treatment for diabetic macular edema. It can be kept when you have traction, sometimes when you have a ERM or a taut posterior hyaloid. Most of the times in these cases also we would try some intravitreal injections initially to see if there is any change. Some people have recommended vitrectomy for non-tractional edemas also, with the proposition that removal of the vitreous improves the oxygenation of retina and reduces the VEGF reservoir. The counterpart is that you have it's difficult to administer any drug after that, as we already discussed, and orthodex can be used. So this is one case of mine who had this taut hyaloid and had received a few injections and was not responding. So underwent a surgery, and then there was a drying of the macula with some amount of improvement in vision, because obviously there's some outer retinal loss and thinning of the retina also. But this patient particular managed to at least not develop a recurrence of edema. Another important question or a scenario that we face day to day in our practice is the coexistence of cataract and diabetic macular edema, and the question of who comes first, the cataract or the diabetic macular edema. So normally for any diabetic retinopathy, it needs to be addressed first and controlled to whatever extent possible before we proceed with cataract surgery. So cataract surgery will on its own increase retinal vascular permeability. So if you have any patient for whom you are doing a fundus fluorescein angiogram who's had cataract surgery in the recent maybe a month or so in one eye, and the other eye is either phakic or previously, you will see there's a lot of diffuse capillary leakage happening in the operated eye, even though there may be nothing else happening. That's because of the general breakdown of the blood retinal barrier as a result of the cataract surgery. So this can aggravate your diabetic macular edema, and it can have a risk of progression of redevelopment of DME can be up to 20 to 50%. So it is important to control the DME with preoperative and perioperative use of your intravitreal agents. So along with ongoing treatment, so you initiate treatment for DME, you give some injections, have some amount of control of the DME, and then proceed with the cataract surgery. And if the DME is still persisting at that time and you need to operate because the cataract is also significant, you combine your intravitreal injection along with the cataract surgery. Another important factor is that, again, the diabetic patients are more prone to develop pseudophakic CME. So that can sometimes be a hitch or a question that you need to sort. When a patient comes to you after the cataract surgery with macular edema, you have the challenge now of deciding whether this is diabetic macular edema or whether this is pseudophakic macular edema. So let's take through a case which is a little bit confusing. So this is a well-controlled diabetic patient with mild NPDR on the fundus, uneventful cataract surgery, post-operatively 1 month, develops a macular edema. You can also see there's some hard exudate over here and everything. So there's a little bit of a cyst shape and all. So first line of treatment, the patient is given topicals. It causes some amount of reduction. So then as a second line, patient receives a posterior. This is our protocol for pseudophakic macular edema. We start with topicals, then we give posterior subtenance triamcinolone, and in the very few who don't respond, we go into intravitreal steroids. So then this patient was given PST, didn't change much. So received IVTA and the edema is gone, vision is improved. But now this patient had a very significant steroid response and required 3 medications to control it. Now 6 months later, the patient underwent the other eye cataract surgery, and lo and behold, developed CME in that eye also. The right eye also had a recurrence of CME by this point. Patient was still continuing on anti-glaucoma medications, and our glaucoma consultants very strongly told us to avoid intravitreal steroids. So now we did an OCTA, and we found that maybe the FAZ is a bit irregular. You can see there are some microaneurysms popping up here, some microaneurysms popping up here. So this told us this might be a component of possibly diabetic macular edema here, and so then we advised anti-VEGF to the patients. So sometimes these cases can be quite challenging, and you will always keep you on your toes and thinking. Some unusual scenario. So there's this diabetic patient and all, and has this massive subretinal fluid over here. So is this diabetic retinopathy? Doesn't really look like it. So we did an angiogram, and we saw that along with extensive diabetic and already lasered proliferative diabetic retinopathy, you can see the laser marks, extensive CNP, but there's also a focal leak happening here. So this is a CSR which is added on to a pre-existing diabetic retinopathy patient, and this was treated by doing a focal laser to the CSR leak and resolution of the fluid. And again, we should remember, we are not just treating an eye, we are treating an individual and a patient. Here is another case where this is a patient with diabetes, hypertension, poor control, presents with a picture with multiple hemorrhages all over, and this very different looking subretinal fluid with intraretinal fluid So this patient had hypergammaglobulinemia, and this kind of a fluid accumulation occurs due to the accumulation of immunoglobulins in the subretinal space and the osmotic gradient which causes the fluid. What is characteristic is that the shape of this, it's described as pillars. It's got a very vertical kind of a shape and appearance of this subretinal fluid as compared to what you would normally see in DME. So sometimes when the pictures are unusual, you need to go a step further and investigate the patient further. And these patients, of course, need treatment for the cause of their hypergammaglobulinemia, multiple myeloma, whatever they may have, and plasma electrophoresis, which will lead to the resolution of this edema. Again, another patient, massive diabetic macular edema, comes to us. We see the patient, and we, of course, do what we do. We advise the patient to have an anti-VEGF injection. This is an OCT of the patient some 2 or 3 months down the line. So what did this diabetic macular edema respond to? Can anybody guess? So when the patient presented to us, the blood sugar levels were 500 milligrams and obviously could not receive the injection, and so the patient was asked to go and get the sugar control, came back to us with better control, still not, and this itself had caused a reduction in the diabetic macular edema. So paying attention to the systemic control is of paramount importance. So to conclude with all of this, in diabetic macular edema, if it is non-center involving, you can observe it or you may do laser. When it's center involving, the first line is anti-VEGF. If there's a good response, you can continue with it. If there's a poor response, you can switch to another anti-VEGF, especially if you have used bevacizumab or ranibizumab in beginning, you can switch to aflibercept or brolucizumab or faricimab. You can add laser to any microaneurysms, you can add on some grid, or you can switch over to steroids also. So just like DME needs a lot of things to be working, this is my team who work with me and have helped me over the years, a lot of them, in making this presentation together. Thank you.